the real domestic and economic security issue of having an unhealthy people here in our country. So it's time that we bring out of the blind spot the reality of inequity in our society and the huge fiscal impact that it's having on us as a whole. And what I try to do is encourage, especially leaders in healthcare, to really hone in on what does inequity cost your system? What does it cost your patients, your communities that you serve? What does it cost your own workforce?
All right. Chris Hemphill here at Meeting of the Minds Wobot Health Podcast. We partnered up with the Future of Mental Health to bring a deeper look at some of these conversations. What you see on stage, or if you didn't have the opportunity, what you might have seen on stage. We like to have a one-on-one where we can go in depth on maybe the topics that we couldn't get to and cover to the detail that we wanted. So today we'll be talking about health equity with Jahmal Miller, who is the Chief Administrative Officer at Mercy Medical Group of Common Spirit Health.
Yeah, absolutely. Yep.
And just to get it to open up the conversation, I wanted to bring up some statistics that we're aware of that like we actually commonly shared. I'm going to start with Satcher Health Leadership's Institute at Morehouse, where they highlighted that between 2016 and 2020, because of lack of mental health coverage, we unnecessarily lost 117,000 lives, costing, and in terms of cost overall, was $278 billion. Deloitte also reports that that health equity, excess spending that is routed back and traced back to health equity, results in over $320 billion in excess spending. So they're really doing a good job at putting a cost to how much it costs to be inequitable, how much it costs to have bias within the system.
That's right.
So really excited, Jahmal. We've got some work to do, and I keep saying it, we can't solve everything on this podcast, but we can get you started thinking down those right paths and territories. And Jahmal, I wanted to brag on you as well as being Chief Administrative Officer, also California's first health equity officer, and wrote a book, Equity, Equality, and Justice for All.
Yes.
So yeah. I'm curious about what you hope that the folks watching get out of this conversation.
For sure, man. Well, thank you, Chris. I'm honored to be here with you today, and I appreciate the brag. I'm just putting that because I try not to brag on myself, but just blessed, man, and to be able to have a platform like this to talk about a topic and an issue that I think is the number one issue of our time. When we think about the importance of health and racial equity and American society, and I think the topic that you led with as far as the cost, it's extremely important for us to explore the real economic cost. Mm-hmm. That's not where the cost started. The cost really started in premature and preventable deaths, compromised quality of life, limited, minimized life expectancy, and those are where the real non-economic costs have impacted people from our communities, from vulnerable communities, underrepresented communities, communities of color, for decades and even centuries since the origin of this particular United States of America. And we're very familiar with that. A lot of us are personally familiar with it, in that our families, our cousins, uncles, aunts, neighbors have been affected by this for many years. But a lot of those who have power and privilege have had the luxury of us being in their blind spot. So I've asked myself rhetorically and literally, how do we center the importance of the presence of inequities in society? And that's where we pivot to the economic implications, which I'm grateful that you started off with around quoting Deloitte's number of over $300 billion annually that costs the American medical system due to the inefficiencies associated with health and racial inequity in our healthcare system. And projected In that same study, towards 2040, if we stay on that same trend and trajectory, it could cost us annually over $1 trillion. And that doesn't even take into consideration the indirect costs associated with it, the lack of productivity, the real domestic and economic security issue of having an unhealthy um, people here in our country, poor rural white people, urban densely populated communities across the country, and a very browning and tanning America that are disproportionately impacted by it. So it's time that we bring out of the blind spot the reality of inequity in our society and the huge fiscal impact that it's having on us as a whole. What does it cost your own workforce? We find that even those healthcare workers across the country who have access to care and coverage, they're commercially, employer sponsored healthcare that they have access to, even those minorities, people of color, women, their outcomes demonstrate those disparities and inequities. And there's a very direct impact to the bottom line of these systems. So it's a moral argument that needs to be made, the ethical imperative as to why we need to do the right thing in seeking justice, social justice, health justice for all people. But just objectively and plainly put, money talks. And oftentimes people literally do not know how adversely impacted our economy is due to disparities and inequities that exist broadly in society, but especially within our health systems, where we spend 18 and 90% of our annual gross domestic product on. So it's a huge opportunity, and I'm grateful in how you've centered that to lead our conversation.
Well, I appreciate the opportunity, and I appreciate hearing what you hope people get out of the conversation. Because think about a world where we feel compelled to lead with economics when it comes to something that is not only just a moral outrage and ethical crisis, but just something that we have to live with every day that results in real health concerns that I think you went over in your presentation a little bit earlier here at the conference, and maybe we can revisit a little bit of that too. Yeah. We kind of established some key learnings to come out of this conversation for the folks out there, starting off with the idea of what's missing in this health equity conversation, stories about your time leading these health equity efforts within California, and how to innovate for equity wherever you stand within the healthcare continuum, the area that you operate in. Yeah. Sound like a good plan?
Absolutely.
Okay.
That's a plan. Let's do it.
Okay. Well, I'm going to talk about cost again, but in a different light. And that light is what I see a lot of health equity leaders experiencing is there's a personal cost to even taking on roles in terms of leading health equity, because you're in I feel like you're often in a position where you're having to shepherd change that was unexpected. Yeah. If people don't understand the extent to which bias and inequities were causing harms, then it's having to educate them about it and turn ways of doing business that they might not want to change. Yeah. So I am curious about your background and what's led you to be so persistent in enacting and driving this kind of change.
Yeah, you're spot on, man. It again, the marginalization of the topics of DEI and specifically health equity. I've been working in healthcare now for over 25 years, and it's been a pretty consistent journey when we think about the term we use as level setting. Getting people to a level of understanding who otherwise would not be concerned about the importance of health equity and social justice or diversity and inclusion. And it's just a fundamental part of the journey to get there. And when I say there, it's like we talk about health and racial equity in only aspirational ways, but I'm interested in attaining it and making it happen. And the reality is that you and I alone, as much of the warriors as we are in health and non-health spaces to advocate for health equity, we can't do it alone. It requires allies. It requires coalitions. It requires alliances. It requires the unusual suspects. Even some of them don't know what their role is in being concerned with the attainment of health equity. So the journey requires education and discourse and conversation initially to engage people. It's kind of like evangelism, or ministry or outreach, education and awareness, because not everyone has the same understanding that we have, both lived, but also some of us may have gotten the training and academic understanding human and civil rights have been, why they're so essential here in the United States of America and around the world. A lot of us grew up in a way that was center and core to who we are in our upbringing. And then we get out into this world, in the communities where we live, learn, work, play, and pray. And as diverse as they are, we find out that many of those who are in powerful and privileged spaces, they've not had those lived experiences. They've been deprived in our academic systems, from K through 12 and optional when they get to colleges and universities, of learning about African American history, which is American history, or global history that informed, the transatlantic slave trade, and so many components of American history that those who have been in powerful and privileged positions have been very intentional, and it's documented, of taking out, our stories and inserting a narrative about our racial inferiority to justify why we were treated like savages and brutes, to justify why you would bring, men, women, boys and girls, babies from the western part of the continent to the Americas, for the purposes of the economy of the transatlantic slave trade. So how do you justify that? You justify that by a negative racial narrative about how we are less than human, to make it okay. And now, when you're in positions of schools being built, or during that time through now, schools being established, hospital systems being established, banking systems being established, all these various systems, institutions, structures that we're a part of now, the origins of that was at a time where those who were in powerful and privileged positions created something that was not necessarily for us. So a lot of people simply don't know that. They've been deprived of that. So we're not going to get it to a place of equity overnight. And a fundamental part of us getting there to achieving health equity is education. How do we hardwire that information into schools? Because it is American history. It's a way of humanizing and giving names and purpose to those who literally built this country on our backs with our blood, economies, for us to become the most powerful democracy in the world. We, against our will, were major contributors and builders, to this state, but yet we don't get credit for that. And a lot of times that credit is not given through the educational, efforts. So that is what drives me to be that advocate, to take the time, even when it's frustrating in the workplace, for people who don't want to center this, just to say, okay, let me be patient, let me understand my audience, let me understand my key messages so I can engage with them and help them understand that at any given time, we can be vulnerable. Even with your power and your privilege, something can happen to your child, to you, that could demonstrate, your weakness by way of being vulnerable and subjected to something that literally disempowers you. And how does that feel? How does that make you approach a system that you're used to being in control of, but now you may not necessarily be in control? So it's like, how do you navigate through that? A lot of times people have never had to think how we've had to think and how we've had to live. So empathy, humanization, and helping people understand that our history is very much so core to our collective improvement as a society, but it's also core to your bottom line. So there's a strong business case for achieving health equity to DEI. So I like to say we meet people where they are, we take the time. You can't reach everyone, but if you center it as a part of the strategy of the organization, show them how we can get there, show them that this is not something in the margins and add on, but it can be a fundamental strategic imperative to all that we do, and not disrupting what you're prioritizing, that can go a long way. And again, it doesn't happen overnight, but it's a journey, it's a marathon, as Nipsey would say, and just one person, at a time. And it's been effective, got a long, long way to go. But people being enlightened about the truth of what American history really is, the good, bad, and the ugly, that's something we have to reconcile with so that more people can genuinely appreciate and have the knowledge, wisdom, and understanding of what the experience has been, particularly of those of the African diaspora, and as well as those indigenous and Native American experiences. And once we start to reconcile with that, I think we can start to make progress.
Thank you for for that background, and it just makes me think that while I did frame up how difficult it is to lead some of these efforts and make some of these changes and deal with the resistance, it's probably a whole lot more difficult in a lot of cases to be silent while watching decisions get made that deny opportunities.
Yeah, yeah, and it's courage is the word that comes to mind. I know we talked about it's a what missing, and I'm probably getting ahead of the questions that you have, but courage and heart. People say like, what's it gonna take, for us to just do better as a society? And it's a spiritual thing, but specifically, you got to have heart. We in many instances, man, whether it's in our political dynamics and communities across the country, oftentimes we need a heart transplant, of just seeing people as people, connecting with each other. During COVID, the physical separation of humanity, I think it helped do a number on us to where we were not able to connect and to touch and to see people. Given the political dynamics that played out, from one, administration to another, the civil unrest with with George Floyd and Breonna Taylor and Ahmaud Arbery, there were just so many major collective traumas that we shared as a society. And one of the difficult parts of transitioning through that is not being able to connect with people. So it's exacerbated a lot of our divisions and a lot of the ills that we've had, especially in the United States of America. And it's happened around the world. And technology, on one hand, has been leveraged for good when we think about, telemedicine and some other ways, FaceTiming, being able to still connect with family, even though we couldn't see them in person. But also technology in a major way has done harm as far as some of the information and exposures that we have had access to. So a heart transplant, not literally, but figuratively, a spiritual transformation in society towards just love, loving one another, seeing the humanity in one another, and letting facts, be facts and science be science. But the truth is, we gotta have a heart transplant of just love and appreciation for just our fellow man, fellow woman, and that's a big part. And then the other word, the C word, is just courage. I look at, I went to Montgomery, Alabama a couple months ago, and we went to Dexter Avenue Baptist Church, where Dr. Martin Luther King, he was called a pastor there, like age 26 or 27. And within a year's time, in 1955, is when the civil rights movement, as we know it, started. And you had the Montgomery bus boycott after Rosa Parks refused to give up her seat. And I was like, 26 and 27. And, you think about him and Malcolm X, Medgar Evers, they were all like 37, 38, 39 when they were assassinated. I'm 47. And during that trip, I was just reminded, and I write about it in my book as well, just like the courage during that time in particular to do what they did, to the extent that, if they had to die, they did. And, progress, relatively speaking, has definitely been made, and we have a long way to go. But in our unique ways of power and privilege that we all, to some extent, benefit from, we see less and less courage sometimes where we need to see more of it, and sometimes leadership requires that we stand alone, lean in and have the courage to do the right thing. If you do the right thing, you can never go wrong. So heart and courage, that's not the science, that's not the data, but the extent to which we become detached from those attributes or qualities, that's where we need to reconnect. And I think that's going to be a key part of our ability to move forward, to really experience, this beloved community that Dr. King so marvelously referenced and documented and talked about. And again, I'm an optimist. I stand on hope. I believe it can still happen. But heart transplant and courage, man.
I really respect the call for finding that courage, and maybe a whole another episode could be about cultivating courage.
For sure.
Part of what you said also makes me wonder. I want to get down into your role as chief administrative officer, because I think that the way that you framed up how we should be thinking about health equity, it implies that a lot of the initiatives, a lot of the efforts are kind of on the sidelines, yeah, whereas these things should be core and endemic. So I am curious about your role. What does chief administrative officer, what's under your purview, and how does health equity fit into that?
Yeah, yeah. So I've been in the Common Spirit Health ministry, the system, for about 4 years now. And I've been Chief Administrative Officer with Mercy Medical Group for 2 years of those four. And Mercy Medical Group is the largest non-academic medical group in all of Common Spirit Health. And prior to my role as CAO, I was Assistant Vice President at Common Spirit for Equity and Inclusion. So that opportunity to lead our national health equity effort to develop our first ever roadmap for health equity, and did that collaboratively with executive leaders across Common Spirit Health. That laid the foundation of my Common Spirit Health experience. So a couple of years into that role, when I was looking at other opportunities within the ministry, it led to this CAO role, where I work closely with our CEO to really administer the non-clinical administrative and operational facets of our practice of over 500 physicians and advanced practice providers. And what I actually documented in my book as well, what I really appreciate about this opportunity I was afforded was that Dr. Alan Schatzel, our Chief Executive Officer, who I report to, he saw as a leading strength and asset of my experience, not just in healthcare administration throughout the course of my 20 plus years at that time experiences in healthcare. He not only saw that as an asset, but he saw my experience around health equity, social determinants of health, leading California's Office of Health Equity as an attribute that could be of benefit to him, the practice. I appreciate that rather because he encouraged something that sometimes leaders don't encourage, and that is, if you don't have that title of being that health equity leader, some people think that you have to be the only one with that title, therefore you're the only one who does that work. And what he's encouraged is what I've talked about for many years, is that, whether you're a C-suite leader or you're on the board of directors or you're a frontline worker, it's everyone's role and responsibility to be an ambassador, an advocate, an activist to achieve health equity and social justice. And he, as a chief executive officer, hiring for the CAO role, saw that as an attribute and not a deficit. And I have always been appreciative and grateful for him modeling and leading the way as it pertains to leadership. And how that has transitioned into my current role, it's transitioned into a number of ways of opportunities to present and to share and strategize with our hospital partners in the greater Sacramento region, speaking to their executive leadership teams, their leading managers and directors about the importance of DEI and how they can integrate that into their respective facilities, efforts within our own practice. Specifically, an example I'm thinking of is a partnership that we established with Johnson & Johnson. So they invested significantly into an initiative they call A Race for Health Equity. And we were able to receive a significant grant, forging a partnership with them between our practice, Johnson & Johnson, focused on health equity in population health research. And the disease focus is peripheral artery disease. So for many years, we've heard about, amputations. We've heard about a number of morbidities or comorbidities associated with issues like diabetes and cardiovascular disease. So when you think about peripheral artery disease, the progression of that has led to a disproportionate number of amputations in communities, in Black communities relative to white communities. And the focus of this effort is to retrospectively analyze the data about patients in our market, and to identify those who are at risk of developing the disease. And we know that disproportionately there is a higher risk for African American and Latino patients. And the gist of this research is to really prevent the progression of the disease. And when and if it does progress, how can we ensure that equitably the last option of amputation or more severe interventions is afforded to these patients, especially for all patients, but especially Black and Brown. And that partnership we launched earlier this year. Dr. Keith Jones, one of our vascular surgeons, is our principal investigator. I have the honor of being like a co-investigator on the project. But forging that partnership, bringing some of our other departments in Common Spirit Health together to administer this research. So being kind of what I call an executive sponsor in that effort to identify the partnership opportunity, identify the funding, bringing key partners within the organization together to make it happen. Our practice has never done anything like that in particular, and we think it will pave the way for what we can do in the future. But that's just one of a number of examples I can use as to how I can leverage my position, my role, and my responsibility and my voice to change the game. And it's not always easy. It's not always fully embraced, to be honest, with colleagues internally and or externally. But that's just how it goes. But for the most part, it has been well received. We anticipate excellent results that will benefit patients and communities that we serve, and also encourage, I think, the voice of many of our clinicians who are also passionate about DEI and specifically achieving health and racial equity in our community.
Well, it is an incredible example, and I appreciate your CEO's vision in going back to that topic that we were talking about earlier, a very specific, oh, that's that person's job, right, but making sure that this is something that's embraced fully institutionally. What I'm curious about is how your background influences the decisions and the mode of operation that you're doing today. Mm-hmm. So I'm very curious about the learnings and experience as California's first chief health equity officer, mm-hmm, and how that translates into the work, the experiences, the stories that you're talking about that's happening today.
Yeah, that was, as Malcolm Gladwell would call it, a true outlier moment. Just always grateful for that experience for so many reasons. But most prominently, why that experience stands out is a mentor of mine that I write about, actually, Grantland Johnson. He was California's first African American Secretary of Health and Human Services, and he served in the Clinton administration in the late 90s. He was one of Sacramento's first Black city council members, first Black county supervisors, and I connected with him in the senior year of my years at Columbia University. Cold call to him, even though I grew up in Sacramento watching him at various levels, I had never met him. Mm. So when I reached out to him, cold call, and he set some time up, and we probably talked for about 2 or 3 hours, and he opened up his Rolodex at the time, if you will, and gave me a number of names after we conversed about my interest in going into healthcare. And early in my career, he was key to helping me land my first job in 1998 with Kaiser Permanente. And he mentored me actively over the many years. But along the way, he would always say, hey, you should go in public policy. You should work in health policy. I'm like, no, I'm good working in private sector healthcare. I'm enjoying it. I'll never work, in health policy or in government. So fast forward to my second term or tenure with Kaiser Permanente, working in a national community benefit office. Another mentor of mine reached out and said, "Hey, Jamal, California is now recruiting and looking to have the governor appoint first ever, health equity officer leading California's Office of Health Equity within the State Department of Public Health." I'm like, "Oh, that sounds interesting." And they're like, "Are you interested?" I'm like, "Yeah," because by then I had learned about like executive appointments or appointments to boards or commissions and how that could be a key, career impacting moment, another way to affect change at scale. So that opportunity of learning about it pivoted to the opportunity of me throwing my hat in the ring. And I went on about my business, man. I focused on the work that I was doing in national community benefit at Kaiser Permanente. And one day I get the call to interview, first round of interviews. And I'm like, okay, cool, this would be nice, and I went in and bombed, so what I thought the first interview. And I said, when I left out of there, I'm like, yeah, God will have a sense of humor if they call me back for another interview. And he definitely has a sense of humor because they called me back. Second interview, I felt that I did much better, and now, in my opinion. And fast forward to extensive process, kind of delays, I finally got appointed to the role. So I'm giving all that background and context to say what led up to it, and then being sworn in October 1st, 2013. It was that whole experience where the weight, the gravitas, of the moment and the opportunity just really hit me in that this is an exceptional, unique, influential opportunity. And as I settled in, I had over 400 meet and greets within my first year, meeting with advocates and consumers, traveling the state, building up our staff to just under 40, had a very, very dynamic group, team, peers that executed on the agenda of the Office of Health Equity. We had an advisory board, and I was just able to meet so many people who were equally, if not more, passionate about achieving health and racial equity in California. And I would always reflect back on Grantland. He was there at my Senate confirmation hearing on July 2nd at the Senate confirmation hearing before the Senate Rules Committee. And within a month's time, he passed away from complications of diabetes. That was his last kind of public appearance. And what the consistent theme from being considered to being appointed, sworn in, confirmed by the Senate, building the team, that 5-year experience, it resonated deeply with me that this is special. This is like not the run of the mill kind of experience. So I started to be inclined to start documenting and writing and sharing because a lot of times our stories aren't told, or they were told and the narrative was changed, or literally the documentation was destroyed. So I felt compelled to be a good steward to capture this moment by starting to write and share the story. So the power of advocacy, the power of public policy, being in such an important executive role and seeing the important role that government plays in our day-to-day lives is something that from that time till now resonates very deeply with me. We did a lot of hard work. It kept me busy. I'm busy now, but that role will always be exceptional and different. And I think what resonates with me now from that experience is just the awesome responsibility that we have, that when you're in the seat to affect change and to make a difference and to open doors for others, just how opportunities and doors were opened up for you, do it. Have that courage, have that heart to do it. And that resonated most deeply with me when I was with the state. So when I pivoted back to private sector, to be honest with you, it's been a struggle, a good, healthy struggle, because that cause, that mission, is sometimes hard to replicate, in private sector. Even when you're working for a mission, a nonprofit-oriented entity, there's something a bit more powerful and impactful when we think about systems transformation, that working in a government setting of influence, that you can help influence, that you can help inspire. Whereas when you go back to your respective organization, system, institution, or what have you in a private sector or a public traded entity, whatever it might be, in that vein, you have an impact for that organization, for that community that that organization might serve. Government, we're in service to all Californians in that instance. So it's trade-offs, but those are some of the highlights, the things that resonate with me now, being an advocate, for change, for the good, for those who are most vulnerable. And that's something that is deeply rooted in who I am. So regardless of where I am, what's going to drive me to transform health systems is the importance of advancing a health and racial equity agenda that achieves social justice as well.
I'm going to dig into a point you made about when you see a door you can open, why not open it? So I'm curious about what you see or who you see as unsung heroes that we should be keeping an eye out for within this health equity narrative.
Yeah. Give me an example. I think I hear the question right, but like if you were to think of an unsung hero, who comes to mind?
I spend a lot of my time focused on the algorithmic aspect. Yeah. What happens when you have data that is from a system that's inherently imbalanced, to where Black patients and Latino patients might not seek care as much as white patients, and thus there's less data reflected. So this, I know her Twitter or X handle or whatever is Math Rachel, but she put together a course. Her course on natural language processing included a full rundown. This is on fast.ai, but it included like one of the sessions was a full rundown on potential biases inherent in natural language processing, and that kind of draws a connection to that. So that's Math Rachel with Fast AI, and it draws another connection to Dr. Timnit Gebru, who she put out a paper in I believe it was 2019. She and Dr. Emily Bender and was it Liz Mitchell? I forget the other name off the top of my head. But these folks put together a paper outlining like the challenges and ethical hazards in the approaches that are being used for natural language processing. They warned about a lot of the flaws and challenges that we see with large language models well ahead. Yeah. And honestly, in Dr. Gebru's case, her reward, not only being unsung, was to be fired by Google, her employer at the time, after putting that paper. So that's just an example of someone who, like, again, I'm coming at it for like I always have these examples around like algorithmic bias and equity and things like that. But it's a story that I don't think gets enough attention or appreciation.
For sure. No, those are great examples, man, and it helps me respond to the question, man. I have a few in mind. Unsung hero that comes to mind for me is Dr. Cheryl Grills. So I had the opportunity to meet Dr. Cheryl Grills, who's a leading professor in psychology at Loyola Marymount, and I met her while I was at the Office of Health Equity. She and her team, we brought on to do the statewide evaluation for our California Reducing Disparities project to demonstrate the value of how investing innovatively in mental health interventions that aren't necessarily evidence-based, but they're more culturally congruent and competent outside of the mainstream, but yet very effective. And her team, was sent to us to evaluate these various programs throughout the state that we were investing in, because most mental health funding in the state of California goes to the 58 counties. And oftentimes, the counties have a history, and other systems have a history of doing more harm than good when it comes to communities of color. So this California Reducing Disparities project was meant to not only identify innovative practices and interventions, but to also, how can we demonstrate from a reimbursability standpoint, from a mainstreaming standpoint, these practices that fall outside of, what has been accepted by a lot of county practices. And her team did a phenomenal job on that front. And that's a piece of why I think she's an unsung hero. The bigger piece is there's some recent work that she has led as a part of California's task force to evaluate and analyze and ultimately report on why reparations should be afforded to people of the African diaspora in the state of California. And in that role, she, put her intellectual, genius as well as that committee to work. But on the front lines of what for some seems very trivial, unimportant, unnecessary, she demonstrated that heart and that courage to stand up as a black woman, speaking truth to power, objectively, ensuring that this process was completed in a way in producing a report that would inform, I think, what will be a day where California will take some meaningful regulatory action as it pertains to reparations. And her cause for social justice, for health and racial equity, particularly within her discipline of clinical psychology, has been second to none. She is a mentor, a friend, someone who I just genuinely appreciate and applaud. Another person that I have the highest regard for, who has been a mentor and a supporter, especially when I was at the Office of Health Equity, is now Mayor Karen Bass in the city of Los Angeles. When I met Mayor Bass, she was Congresswoman Karen Bass, representing her district in Los Angeles. And she was just a strong advocate at congressional levels for health and racial equity, especially as it pertains to at-risk and foster youth. She is someone who just provided great guidance and advice to me and who's been on the front lines since her time of being a local leader in LA to ascending to be the Speaker of the Assembly in California and then ultimately going to Congress. And she has broken, window glass ceilings. She is the first African American woman to lead the city of California, and likely the first to lead one of the largest cities in the United States. And she is a phenomenal person, a bright thinker. LA is better off having her in that seat. And I'm very grateful for the time that she took while I was leading California's Office of Health Equity to lean in and to show me some of the tricks of the trade of how you get things done effectively. And the last person I'd like to highlight as an unsung hero is my friend Aletha Maybank. Um, Aletha Maybank is the American Medical Association's first ever Chief Health Equity Officer. She and I met on a health equity research trip to Cuba years ago in 2014. I was leading California's Office of Health Equity. She was the health equity officer and chief in the city health department in New York City. And so we would exchange ideas from a state level, from a city level. They were doing some progressive and hugely impactful work under her leadership. And in her role with AMA, the largest medicine trade in the United States that has been around for well over 100 years, she has kicked down doors. She has challenged the status quo with a very progressive multi-year strategic plan for achieving health and racial equity. And it takes a lot of heart and courage. And I know she's taken a lot of fire, but yet has had a lot of good support around the country and has really galvanized a different kind of conversation when we think about how healthcare systems, and particularly medicine, is starting to embrace and reevaluate and reconsider why health and racial equity is important. So I could go on, but those are, my unsung heroes, not to mention just the everyday person that, might be poor or homeless or, the single mother, with a son who might need a mentor or might need some inspiration. Those are the real unsung heroes that we advocate not only for, but with. We speak on their behalf, and we do what we can in positions of influence on their behalf, because that is when we say equity for all, that's the all. not for some,
Mm-hmm.
but all people. So those are the real unsung heroes, and I'm sure that the folks that I referenced would probably share that sentiment. But I give them kudos and props on how they have inspired me to be who I am. I don't have it all down packed, but I'm grateful what they've influenced me to do, how they've educated me to some things and helped me be a recognized, leader in health equity that I am.
Well, thank you for sharing multiple stories of incredible people. It makes me wonder about opportunities for innovation within health equity, like to highlight this is not a pointless grind, it's not trench warfare.
Yeah.
So what would you see as opportunities for those who are focused on innovation and change within the health equity domain?
Yeah, I'm big on social innovation. Oftentimes, social innovation does not exclude technological innovation,
Mm-hmm.
but really social innovation is about how are we leveraging the advent of technology, biotech, biodesign, and others within the context of social change? How are we applying it for the greater good? And that's where social innovation comes in to play. And one example that I learned about earlier this year and that I am just still deeply impressed by is particularly Stanford University. Stanford has their Byers Center for Biodesign. And among other things, this center is literally a health tech, med tech pipeline. They pride themselves and they're known around the world for this innovation fellowship, this training program where they bring clinicians from all around the world to train in identifying by way of their curriculum what is the issue that you want to fix by way of med tech invention, health tech invention, biodesign, biomedical engineering, identifying what's that issue that will make healthcare more efficient, foster better outcomes, so on and so forth. The second part of that, really, how do you invent? Literally inventing that med tech, that device to affect change in how medicine is administered, how operations are done, how life sciences are done. And then the third part of that process is implementation. How do you package that up and prepare to pitch it maybe to private equity, venture capital, other science, life sciences companies that might have an interest in acquiring your device or partnering with you in some way, shape, or form. And what they've infused into that biodesign center is a deep, sincere interest to health equity and inclusive design. And a good friend of mine who I worked with at the Office of Health Equity is now advising them on health equity and inclusive design, Dr. Tamu Nolful. And the reason is they wanted to bring together, this great Silicon Valley-based resource at Stanford University that's been around for over 20 years, and coming out of COVID, being very explicit about how can we bring this biodesign effort to where it could be of greatest benefit. And one of the areas they're focused on is not only a strategic focus on health equity and inclusive design, is HBCU partnerships. That's the second part. And it's this understanding that as a predominantly white institution, well-resourced, understanding that there is also a disconnect and looking at the demography of those who have been trained in biodesign and the opportunities that come with this to launch a startup, but to also benefit financially from those startups. And it's a whole different opportunity around advancing health and racial equity that you often don't hear about. So they understand what they don't know and what they don't have and wanted to bring expertise in. And they also want to partner with HBCUs, not to bring like, hey, we're Stanford and we want to come in and run things. They understand that some of the best and the brightest talent that's out there are in undergrad and graduate institutions, specifically HBCU schools of medicine, and they want to bring the two together. So it's mutually beneficial. And I think that's a game changer. And I'm excited that Dr. Tamu Nolfo is there advising them in that space. And just on the outside looking in, I think it's good for people to know that, especially if you're at an HBCU, this biodesign work isn't a game changer. It's extremely important to see the health equity and the inclusive design component to it. And a lot of times strategic partnerships like that can help us get to the next level. So that is one of the most recent innovations that has been most impressive to me. It touches on everything from the role that generative AI can have.
One thing that that Biodesign Center is doing is they're facilitating a space for people to ask the questions that historically they hadn't been asking,
Yes.
but then go all the way back to that point that you were making earlier about health equity not being a side project. Yeah. Because okay, if we're in a capitalist society and playing the capitalist version, yeah, of what we need to bring what's right to our communities, mm-hmm, then let's do that from the ground up.
From the ground up, man. The analogy I use is like you bake a cake. You know, so many times when we do stakeholder engagement, we bake the cake and then we ask for input. You know, help us put the frosting on. And then we find out that that carrot cake that we made, it has nuts in it. And the folks we want to serve it to have nut allergies. But if from the beginning, the nascent phases of the idea to create a new biotech solution or a new device, from the early phases, if you're thinking about health equity and inclusive design from A to Z, now you're producing something, especially if it's around the algorithms, generative AI, robotic, processing automation. You've created something in a more culturally congruent, linguistically appropriate way, and it just wasn't tagged on at the end. But like you thought about this from the beginning, and that is one of the key drivers as to why they're doing it.
Well, I'll say this too. You made another point earlier about the need for courage. Mm-hmm. Well, courage, like thinking about a whole business operation has been put in place, the science has been done, and all this stuff has been developed, and there's been millions of dollars of investment. And then they come in for that frosting. And when that health equity frosting starts to say, wait, look a minute, fundamentally, this was a challenge all from the get-go, yes, and it cost millions of dollars to change, yes, then that requires a high degree of courage to bring up that point. Yes. But it requires a much lower degree of courage to, like, while you're still in the design, before you've, but so by addressing this early, because we know that courage is not held by everyone. That's right. So if we can create a scenario where it doesn't take as much courage to get the kind of change that we need, then we're
going upstream, because it's like it's the difference between prevention and intervention. How about we prevent this from happening in the first place, because it's going to be far more difficult to repair it after it's happened, and sometimes impossible to fix it or repair it. And that's where repair with regard to inequities, inequality in our society, we've got a long way to go and a lot of work to do. And some people just, they don't want to have the courage nor the strength. They don't have the emotional or intestinal fortitude to want to do it. So to your point, it's like, it's easier down upstream, yeah, versus downstream. And it's like, man, stage 4, cancer diagnosis. It's hard at that phase versus upstream. How about we stop the cancer from in the first place if we can, or diagnose it as early as possible? And we know that some of the most egregious disparities and inequities that exist for our people, it's a later diagnosis for a number of reasons, and quality of life has been compromised. Early death, premature death is almost guaranteed, and we can stop that. We can disrupt that by doing what you said, courage that is less, requires less of you earlier in the process, versus big C courage downstream where you're really fighting an uphill battle.
Well, when you started making that line around prevention versus intervention, I knew it was going to go back to healthcare, mm-hmm, specifically. But a big question that we ask everyone, this is not a Marvel movie that we're watching right now, but we're going to grant you a superpower. And that is going to be able to change any one aspect of anything about how healthcare is delivered. If you had the power to focus on just one thing, what would that be?
Man, it would just be a strong dose of the reality of how anti-Black racism and indigeneity is baked into medicine and our healthcare delivery system. Because that understanding, it's a block right now for people. If you haven't had a lived experience, even if you spent time educating yourself when you personally have knowledge and understand the weight, the traumatic generational impact that institutionalized racism and discrimination has had against people in this country, especially Black and Indigenous people, it can't help but elicit action, restorative and reparative action to reconcile what was done, how it's still affecting us today, and what we will do in the future to resolve and mitigate that. And there are stories around the world where, not perfectly, but certain parts of the world, countries that have come to grips with the extreme, realities of traumas done to millions and thousands of people around the world. And it's a big step towards reconciliation, and it's ongoing. And I don't think here we've really gotten there yet, because we're even still having conversations about reparations to address the impact that anti-Black racism and indigeneity has played out. So that would be my superpower, especially in medicine, because the cumulative impact of living, learning, working, playing, and praying in an ecosystem that wasn't built for you, no matter, how educated you might become, you might reap the benefits of some privileges, the weathering effect of living in an ecosystem that's not conducive to your existence, it catches up with you and starts to show itself by way of mind, body, and or spirit. And you ultimately will end up super duper stressed out, anxious, fatigued, your immune system compromised. You don't get the best sleep at night. And it weighs on you. It literally weathers on you over time. And that's not okay. And so I think that we share this information to inspire, and call people to action. And we have to tell our stories about the realities of what has transpired, who it's disproportionately impacted, and how can we transform this ecosystem into one that is truly equitable. And we cannot get there unless we have a deeper, broadly shared understanding of what American history has been. The good stuff, the great stuff, the neutral, and the extreme horrors that have happened, all of it. And once we start to do that, we can make progress. So there are tactics to suppress it right now across this country. But I believe, we always rise like the phoenix. That being said, why do we always have to rise like the phoenix? Why can't it just be, an open, equitable educational opportunity to tell our stories? And a part of that story is the impact that racism and discrimination has played and been in the DNA of American history. That being said, we can still get there, but we can't fool ourselves by avoiding and only talking about the wins. But we got to talk about, where we didn't get it right and how we can fix and repair that, and how everyone can benefit from equity, and not just, the little black and brown people, or not just the LGBT. All of us benefit from all of us getting in on this opportunity. So if I have a light, you have a light, or the analogy is this, I have a candle that's lit, you have a candle that's not. I hand my light over to you. Now both of our candles are lit. I didn't lose anything. You gained. So if you do that for the person to your right, I do that for the person to my left. Now we've got an illuminated society. No one lost anything, but we all gained by an enhanced, enlightened experience. And there's power in that. And that's what people need to understand, that equity affords to all of us.
This was a very in-depth conversation, and even though it was in-depth, there's obviously more, and there's obviously you've got your book, and you're sharing your actions and what you're going through, and the efforts that you're leading. I'm just wonder where can people go and follow, or where can they find the book, et cetera?
Yeah, thank you, man. It's JahmalMiller.com is the easiest way, JAHMAL Miller.com. And the name of my book is Equity, Equality, and Justice for All. Born to be an Advocate is the timeline. It's about 130 pages,
That's
so
an
it's not,
airplane read,
not
right?
dense
Yeah.
reading, but it's powerful in that, again, it's not a memoir that is just me centric, but it's about what inspired me, who I come from, why I'm inspired to do what I do, and from the feedback that I'm getting, people appreciate the transparency and vulnerability in some instances of sharing, not just, about my experience leading California's Office of Health Equity, but, what has happened since leaving the Office of Health Equity and what led up to me being appointed by that. So if you go to JahmalMiller.com or if you search on Barnes& and Noble, Amazon, any book distributor or book store across the country and around the world even. And I encourage, people to buy it, to reach out, share your thoughts with me. I'm on LinkedIn. .com as well, and would love to stay connected to people. But really honored to have this book out. That was released in May, and it still sounds wild to refer to myself as an author,
You're an author.
but I'm
That's
grateful for that.
among many, many great things. Author is one among that list.
Yes.
Jahmal, I can't thank you enough.
Thank you, Chris.